Academic CME. Today presentations are from the Department of General Medicine, Obstetrics and Gynecology and Psychiatry, along with it faculty presentation from the Department of Pharmacology. So first I would like to call Dr. Adarsh, second year PG from the Department of General Medicine.
Good afternoon, one and all. Today, my topic is on chemical meningitis, a rare case report. 45-year-old male came to the emergency department with the chief complaints of fever with chills, headache, vomitings, and altered sensorium. History of present illness: patient was asymptomatic till previous day, and after which he had a thick yellowish discharge on bending forward, for which he consulted otorhinolaryngologist and at an outside hospital, and he was advised and the doctor advised CT cysternography, for which the patient underwent CT cysternography on 20th August at 8 p.m. with intrathecal contrast. After a couple of hours, patient developed severe headache with throbbing type associated with photophobia, aggravated with neck movements, associated with 2 episodes of projectile vomiting consisting of food particles. After 30 minutes, patient developed altered sensorium in the form of irrelevant talk and behavior. And coming to past history, patient is a known case of chronic sinusitis. See, on CNS examination, patient was conscious but irritable and agitated. On examination, Kernig sign and Brzezinski's sign are negative. Deep tendon reflexes are normal, and plantar reflexes or flexors on both sides. And remaining CNS examination couldn't be done as patient was irritable and non-cooperative. And rest of the examinations, such as CVS and respiratory and parabdomen examinations, are normal. Provisional diagnosis is chemical meningitis and iatrogenic bacterial meningitis. And the prophylactic treatment given was meropenem 2 grams IV 8th hourly, linezolid 600 mg IV 12th hourly, and dexamethasone 8 mg IV 8th hourly. Fluids and cilnidipine was given as patient was a known case of hypertension and he had a high level of blood pressures. These are the blood investigation reports which showed WBC count of 15,000, polymorphs 91, and CRP elevated, remaining normal. And this is the MRI showing ventriculitis and subtle leptomeningeal enhancement. Coming to CSF analysis, cell count was 22 cells per millimeter, and protein was elevated, and glucose was normal, and CSF PCR was done, and it came out to be normal, ruling out bacterial meningitis. Diagnosis was confirmed as chemical meningitis. And meningitis, coming to discussion, meningitis is defined as inflammation of the leptomeninges of two inner layers, pia mater and arachnoid space, and CSF is within the subarachnoid space. And bacterial meningitis is caused by bacteria such as Streptococcus pneumonia and Neisseria meningitidis. And viral meningitis can be caused by Coxsackie virus and herpes simplex virus and varicella zoster virus. And fungal meningitis is often quite rare, and it is caused by Cryptococcus neoformans. And differences between bacterial and viral meningitis: bacterial meningitis is sudden and rapid progression will be there, and whereas viral meningitis is gradual and slower in progression. And severity: bacterial meningitis is severe and life threatening when compared to viral meningitis, and CSF appearance is turbid, whereas clear in viral meningitis. And CSF WBC count is elevated in bacterial meningitis, and protein is also elevated, and CSF glucose is low. And the patient improves with antibiotics in bacterial meningitis when compared to viral meningitis. Chemical meningitis is a rare manifestation with less than 100 cases reported till date. It occurs when non-infectious substances irritate the meninges, triggering inflammation without bacteria or pathogens detectable in CSF. It can result from intrathecal medications, contrast agents, or cyst contents leaking into the CSF. The difference between chemical and bacterial meningitis: chemical meningitis is non-infectious and occurs soon after drug administration or surgery or cyst rupture, and CSF culture will be negative when compared to bacterial meningitis, and CSF cell count is mild to moderate, whereas it is high in bacterial meningitis, and CSF protein is elevated in both chemical and viral meningitis. Bacterial meningitis, CSF glucose is normal, and chemical meningitis is often milder and fever may be absent or present, whereas there is high fever in patients with bacterial meningitis, and clinical course in chemical meningitis improves rapidly after withdrawal of offending agent or supportive care, and bacterial meningitis is progressive and life threatening without urgent antibiotics. Conclusion: chemical meningitis is a diagnosis of exclusion that must be considered in patients experiencing fever and neurological symptoms who have had direct intrathecal injection. It is believed that any molecule can be the cause. Chemical meningitis must remain indifferential in a multitude of scenarios. Early diagnosis and treatment improves the outcome of the patient with chemical meningitis.
Why does CRP relevant in this case?
Since so the patient was given contrast at an outside hospital, sir. Since healthcare associated meningitis can be considered in because
So you also consider the possibility of some bacterial contamination.
yes, sir.
So how can you exclude bacterial meningitis?
Bacterial meningitis we didn't exclude, sir. We treated in that way also, but basing on the reports and investigations, we excluded.
So you mean to say that it could as well be due to bacterial meningitis and not just chemical
Yes,
meningitis?
sir. Probably different.
What is that chemical which is in the contrast?
Iodinated contrast, sir.
So it was given intrathecally.
Yes, sir.
For a nasal sinusitis.
Yes, sir. Patient had nasal discharge.
Oh, that
And
is
patient is a known case of chronic sinusitis. So doctor advised outside, sir. It didn't happen here, somewhere outside hospitals.
What do you mean by intrathecal? Into the spinal canal by doing intrathecal, you said, no?
Yes.
Where did they give the contrast? Lumbar root.
Sir?
Lumbar spine.
Yes,
spinal. There they introduced.
Yes, sir.
Okay. So iodine material produced.
Yes, sir.
Now, what is the literature says about that contrast producing this type of chemical meningitis? You understood the question?
References I mentioned, sir.
Okay.
Now, for simple nasal discharge, such a extensive investigation they'll do.
Actually, when we
Is
asked,
it indicated in this case?
actually when we asked patient, ma'am, is according to the patient and patient attendants, they told that he had sudden nasal discharge. And he might be having before also, ma'am, but we have no documentation. They didn't tell us that he had before also.
Sudden nasal discharge, such a deep, like such a.
Nasal sinusitis and almost half the population are suffering.
Oh, I don't go there. I always suffer with nasal discharge.
Probably they suspected meningitis and then thought they do LP and then put a contrast study and all that probably. They're outside.
Yes.
Leak
Yes, sir.
from the brain.
Yes.
Suddenly, does it occur, the CSF leak? Unless there is a trauma?
Madam, actually the suspected CSF rhinorrhea. As the patient bent forward, there is a sudden gush of nasal discharge. The suspect CSF rhinorrhea, which is unlikely because the discharge is yellowish in color. Actually, in CSF rhinorrhea, we get a clear nasal discharge with glucose. But they suspected CSF rhinorrhea, that's why they went for cysternography. And as they injected that contrast material into the subretinal space, he developed chemical meningitis. The symptoms developed within 2 to 3 hours after the injection of the contrast. That doesn't happen in case of a bacterial meningitis. Actually, in case of bacterial meningitis, it will take some 6 to 24 hours for the symptoms to develop. But here, the patient developed within 2 to 3 hours. High-grade fever, chills, and rigor, and there's a dramatic improvement with steroids. That also doesn't happen with bacterial meningitis. And the patient is having ventriculitis. If it's ventriculitis, the penetration of the antibiotics in the ventricular space is also somewhat, it takes time. So for the patient to respond, if it is a bacterial ventriculitis with meningitis, it will take some 7 to 14 days. But he responded within 1 day for the steroids. So it's more like a chemical meningitis rather than a bacterial meningitis. In the clinical scenario and the patient response, we feel it's a case of chemical meningitis more than a bacterial meningitis. In case of chemical meningitis also, the response initially is a neutrophilic response in the CSF. Later turns to eosinophilic or lymphocytic response. So it is not based upon the CSF findings or the CSF biofire. It is basically depending upon the symptomatic treatment and then the response by the patient. Right. Sir, I also saw 2 to 3 cases of chemical meningitis after after doing CSF cysternography, sir, while I was studying in KGS. Why that happens? It probably depends upon the material that is being used for that. We are injecting directly into the CSF space. By giving IV contrast, the amount of contrast material that enters into the CSF probably it is comparatively lesser, sir. Here we are directly injecting into the CSF space. Yes, sir. No, sir. It's a chemical reaction, inflammatory reaction.
The iodine contrast is known for meningeal irritation. In the beginning, we used to use a Conray for the spinal cord imaging. So those days they used to develop conversions and they become bad also because of the reaction only.
Thank you. Next, I would like to call. Good afternoon, everyone. Today I am going to present a case of abruptio placenta. My moderator is Dr. R. Arvind, sir, Department of OBGY. A 24-year-old unbooked antenatal G2P1L1 with 34 weeks of gestation, who is resident of Pathapatnam, belonging to low socioeconomic status, was referred to GEMS from private hospital Pathapatnam in view of absent fetal heart sound, intrauterine death, and abruptio placenta. Her LMP was 10th September 2024, EDD was 17th June 2025, scan EDD as per 8-week scan is 27th June 2025. Presenting complaints, patient went to the outside hospital with complaints of bleeding PV, which is dark red in color, since 5 hours, complaint of decreased perception of fetal movement since 5 hours, with abdominal pain and back pain since 1 day. Injection dexamethasone 6 mg and injection tramadol IM stat were given there. Later, they referred the patient to GEMS in view of IUD and abruptio placenta. Patient had regular antenatal checkups at private hospital Pathapatnam during first and second trimesters, which was uneventful. Iron and folic acid supplementation were also taken. During third trimester, she did not have regular antenatal checkups. She complained of bilateral pedal edema since 10 days up to the level of knees, not relieved by rest. Complaint of abdominal pain and back pain since 1 day, associated with bleeding per vaginum, which is dark red in color since 5 hours prior to admission. Complaint of decreased perception of fetal movement since 5 hours prior to the admission. Past obstetric history, she delivered a full-term male child by LSCS in view of prolonged PROM with birth weight of 3 kg. Baby is active and healthy. There is no significant past history.
and no significant personal history. She's not having any history of addictions like smoking and cocaine abuse. General examination, she's having pallor, bilateral grade 2 pedal edema. Temperature was febrile. At the time of admission, BP was 160/90 mmHg with pulse rate 104 beats per minute. Rest all vitals were stable. On obstetric examination, on inspection, a suprapubic transverse scar was seen. No abdominal wall edema. Palpation, uterus corresponding to 34 weeks, tender and irritable. Scar tenderness is not present. Symphysis fundal height is 34 centimeters. Fetus is in longitudinal lie with vertex presentation and head is unengaged. Fetal heart sound is absent on auscultation. Perspekulum, bleeding through os is present, which is dark red in color. On pervaginal examination, cervix is soft, posterior, uneffaced, os admitting tip of finger, and vertex is high up. A 24-year-old antenatal G2P1L1 with 34 weeks gestation with post-cesarean pregnancy having irregular antenatal checkups in private hospital Pathapatnam was referred to GEMS in view of absent fetal heart sound, intrauterine death, abruptio placenta. On general examination, she is having pallor, bilateral grade 2 pedal edema. Her pulse rate was 104 beats per minute and her BP was 160/90 mmHg. Per abdomen, uterus is corresponding, height of the fundus is corresponding to the period of gestation. Uterus is tender and irritable. Fetus is in longitudinal lie and fetal heart sound is not audible. On perspekulum, bleeding through os is present. This is a provisional diagnosis, maybe due to preeclampsia with intrauterine fetal demise with antepartum hemorrhage, possibly due to grade 3 abruptio placenta. All routine investigations were sent. Her HB at the time of admission was 9.3 gram per DL, platelets 1.25 lakhs, total counts 22,400. Serum creatinine was 1 mg per DL. Total protein was 5.9. Rest all investigations were within normal limits. LDH is 963 international units per liter. Serum uric acid is 6.1 mg per DL. In CUE, albumin is 3+. Antenatal scan, position of placenta is fundal body anterior, which is grade 2 maturity. AFI is 8 to 9 centimeters. Estimated fetal weight 2.2 kg with gestation age of 34 weeks 1 day. Impression, single intrauterine fetus in cephalic presentation corresponding to 34 weeks 1 day with no evidence of fetal heart rate, feature suggestive of intrauterine death. Her BP at the time of admission was 160/90, for which we have given labetalol 20 mg IV stat and injection MGSO4 loading dose was also given and case was posted for repeat emergency LSCS. Intraoperative findings, previous scar was intact, lower uterine segment is not well formed, bladder was drawn up, Leica meconium stain inadequate, covular uterus is seen intraoperatively, omental adhesions were present to anterior surface of the uterus, baby presented as vertex, left occipita anterior with single loose loop of cord around neck and delivered. Single dead preterm male baby was delivered on 12th May 2025 at 10:33 p.m. with birth weight 2.3 kg. Placenta was fundal anterior and retroplacental clots of around 500 grams were removed. This is the image showing covular uterus and retroplacental clots. Postoperatively, 1 PRBC transfusion and 2 FFP transfusion was done. Patient was pale and bilateral grade 2 pedal edema was present. Her temperature was 100 degrees Fahrenheit with pulse rate 128 beats per minute and BP 140/90 mmHg. Urine output in 1 hour is 20 ml. So case was diagnosed as query postpartum AKI, partial help with impending DIC, and case was shifted to MICU for close monitoring and treated by multidisciplinary approach. She was kept on injection piptas and clindamycin, tablet labetalol 100 mg BD. Injection PCM was given accordingly. Vitals were maintained stable and her urine output is normal after following the above medications. 1 PRBC transfusion and 2 RDP transfusion was done on post-op day 2. Her investigations preoperatively and postoperatively were like this. On preoperatively, her HB was 9.3 grams. After the surgery on POD1, repeat HB was 7.5 grams. On post-op day 2, 1 more blood transfusion was done, and on post-op day 3, her HB was 9.8 grams. Total leukocyte count gradually decreased, and her platelets on post-op day 1 and post-op day 2 were on decreasing trend, and RDP transfusion was done. On post-op day 3, her platelets were 1.2 lakhs. Albumin also gradually decreased. Serum creatinine preoperatively and on post-op day 1 was 1 mg per DL. And D-dimer is 6,395 nanograms per DL. on preoperatively, and LDH is 963 international units per liter. Uric acid is 6.1 mg per dl. Serum fibrinogen was also 114.2 mg per dl. Urine culture sensitivity and blood culture sensitivity were also sent, which was sterile. CRP at the time of admission was 81.72 mg per dl. Case was shifted from MICU to eclampsia room after the patient was stabilized. Drain removal and dressing was done. Her BP readings were controlled until POD4 on tablet labetalol 100 mg BD. Due to high BP recordings on post-op day 5, she was changed to tablet cilnidipine 10 mg BD, and patient was discharged on post-op day 8 on tablet cilnidipine 10 mg BD. Thank you.
Prior to admission,
Sir.
she had edema of feet for the past 6 days. But we have not mentioned whether they have recorded BP or not, because we are telling that a gynecologist is seen there. So is there any mention about the BP and any treatment she has taken?
No, sir. She's having irregular checkups in third trimester, sir. She just complained of pedal edema since 10 days, sir.
No, actually, after going there, somebody might have recorded,
She didn't go 10 days prior, sir. She had on and off checkups in third trimester. First,
No.
Sir.
Before coming over here,
Okay.
she has gone there, From there only she came here,
Yes, sir.
So they might have recorded that
High yes, sir.
recording might be there here. So this what you want to attribute to the fetus and to this problem?
Sir?
It is due to hypertension.
Yes, sir.
Is it not?
Yes, sir.
So you should have asked whether the BP is recorded or not.
Yes, sir.
And they might have recorded it. Whether you have noted or not, I got a doubt. So that is one point.
Yes.
Okay. Without examining, without ultrasound, why? How could you say it is a grade 3 abruptio?
Intrauterine fetal death is also there, sir.
Aithe?
That will come under grade 3, sir.
You cannot take intrauterine death into consideration, What is the grade? Tell me. What is the first grade, second grade, third grade?
Grade 1, no complaints, but retroplacental clots can be seen intraoperatively, sir. Grade 2, fetal heart sound will be present, but she will be having signs of abruptio placenta, sir. Grade 3, signs of abruptio placenta with intrauterine death, sir.
Okay. The treatment, once show me the treatment. Why do you want to give cortisone,
Sir, she had temperatures immediate post-op after blood transfusion, sir. So hydrocort was given thinking it is reaction. Later settled, sir, temperatures.
So how can you say it is a blood transfusion reaction? What made you to think over that? She got a fever. If you got a fever within 24 hours, so you think it is a transfusion reaction? Because cortisone is contraindicated because she is already having hypertension now. Unless it is their necessity should not give, But we are attributing it to the blood transfusion because she is having fever. Is it so? Then why do you want to give optoneuron? See, this is a lesson for all of you. When a patient is very bad, don't give unnecessary things. Optoneuron is not an emergency now at that time. We don't know which drug is causing some reaction nowadays. Unless that drug is 100% necessary, you give. Optoneuron you can give afterwards also. There is no urgency,
You peptides and clindamycin, such a higher antibiotic you started for a simple case. Is it essential to start such a normal case maybe? Peptides
Initially, she was kept on Zostem, ma'am.
Zostem.
But later, her urine output and CRP levels were also increased to 81, ma'am.
Okay, because septic, some focus
Yes, ma'am.
infection.
IUD is also there.
Okay. So why do you want this? Why do you want to present this case? Such a rare case it is. To see
Ma'am,
that?
timely intervention can prevent maternal mortality, ma'am.
Maternal mortality. So what could be the reason for this abruptio in this case?
Preeclampsia could be the cause, ma'am.
But normal BP is not that much high, 160, 140, 90. Many cases we see that. Such an extent it went to abruptio with IUD. What could be the reason for that also?
She didn't have regular antenatal checkups also, ma'am.
Okay, maybe because of that. Relation between the abruptio and hypertension. Why the hypertensive patients are more prone to have abruptio? Any specific reason? Can you tell that?
Anoxia in decidual vessels can lead to premature rupture and the separation of placenta, ma'am.
Okay, and so what is the cause for IUD here in this case? Even simple abruptio causes IUD or maybe
Preeclampsia, one of the cause can be preeclampsia, abruptio, ma'am.
okay, yes. So such an extent of what is the cause for covariary uterus here? Was there any atonic PPH also in this case?
Intraoperatively, blood loss was more,
Blood-
ma'am. No atonic PPH.
No atonic. The covariary uterus is maybe one of the reasons
Extravasation of,
also.
extravasation of that retroplacental
Totally,
bleed
yeah.
into the musculature can cause
Yes.
covariary uterus.
Totally, it became bluish color also. So covariary uterus is the one. Many people they say covariary uterus is the indication for hysterectomy also, cesarean hysterectomy. Does
No,
it
ma'am.
so?
No, ma'am.
All the cases no.
It's
What are
just
the
an intraoperative finding, ma'am.
what are the cases which need hysterectomy in such cases? Covariary uterus.
Postpartum hemorrhage, ma'am.
PPHs. So, what are the name given to the cesarean hysterectomy? Also, we say that
Ma'am?
cesarean hysterectomy. Other name given to cesarean hysterectomy? Peripartum hysterectomy. I just want to tell you that.
One thing I want to ask you, what made you to take a decision for cesarean section? Because she is having already post cesarean, you have gone to that, or what are other things you want to?
Post cesarean pregnancy and pervaginal examination os is also closed, and induction delivery interval might be.
You have not tried, induction. You have not directly
we,
have taken.
We did not
Why-
plan, sir.
Why you have not? planned?
Patient might land into complications.
Why? What complication?
Disseminated intravascular coagulation.
By the time you have seen it, there is no
DSC,
dick,
You mean
You can try actually, because abruptio placenta, if you do ARM, the clots will be going and uterus start acting. Okay?
Okay, sir.
Suppose you are in a periphery and no facilities is there. In such cases, you can do ARM and wait for some time. The clots, after the removal of the clots will come, then uterus will act. And again, that to IUD, that is why I am asking. Is the patient is not.
Here in this case, there are other compounding factors. Her,
Yes, yes.
her creatinine
D-dimer.
is 1 milligrams. She
D-dimer.
has a low platelet count, and her D-dimer is also very high. And but for the timely intervention to deliver, she could have landed up in irreversible AKI. So it's very prudent in this case to deliver early and see all the aftermath of the complications of severe preeclampsia as well as abruption. She is very much vulnerable to develop AKI. And in fact, she had gone into it, but luckily she timely recognition in the post-operative period and multidisciplinary treatment that has not only saved her life, but also recovered from her impending AKI. So it is the timely delivery in such cases that can save lives and that can save complications.
No, it is true. Suppose this is the institute where specialties are there and other things. Suppose if you are alone, then for wasting time, you can try ARM and you can try. Meanwhile,
abruptio placenta is such a dangerous condition. It should not occur. If it occurs, lands into many complications like renal failure is the one, kidney failure is the one, complication DIC is the one, and severe atonic PPH is one. The three complications inevitable, they will occur. But luckily, patient came out because of timely intervention. Also, one of the reasons. Also, she came out safely. So that's one of the factors. Also.
That is the reason. Another thing is, when you are treating a post-cesarean pregnancy, so she had 3 visits with there are gynecologists are there. They should have properly counseled her. Anything comes, you have to come to me. Don't delay. Some problem. So they would have saved the baby had she come early. So the moment she had edema of feet, she should have rushed to the doctor. She has not come for 1 week. So in the 1 week only, the disease might have progressed, That is the thing. For every Caesar, you have to tell from the beginning, you have to come to a specialist only. Don't delay. Any small thing, you have to come. Okay.
Thank you, sir.
Thank you, Divya. Next, I would like to call Dr. Neelima, first year postgraduate from the Department of Psychiatry.
Good afternoon, everyone. I'm Dr. Neelma, first year postgraduate from Department of Psychiatry. I'll be presenting a case of persistent delusional disorder. My moderator is Dr. S. Pratima Mam, senior resident. Identification data. A patient is a 57-year-old female, studied up to 3rd class, widowed, Telugu-speaking, housewife, belonging to low socioeconomic status, was brought to her OPD by her son. Information given by the informant was reliable, consistent, and adequate. She came with chief complaints of belief that worms are present over her skin, repetitive skin picking and scratching, and disturbed sleep since 6 months. History of present illness. Patient's symptoms started 6 months back. She started believing that worms are present over her skin and started picking her skin to get hold of these worms. After a month, she had an ulcer on her right buttock and she started scratching the ulcer, and she started picking the skin over ulcer and showing the skin and hair strands as worms. She also complained that the worms are biting her ulcer. She described that these worms are white in color, and she used to scratch her skin and showed them as worms, but when observed, there were no worms. She even stopped eating food with her hands. She started bathing 3 to 4 times a day to get rid of these worms, and she couldn't sleep during the nights. Past history, no significant past history. Family history, no history of psychiatric illness or neurodevelopmental disorders in the family. Her husband passed away 7 years back, and she has 1 son. Personal history, birth and development history are uneventful. Educational history, she studied up to 3rd standard. Marital status, non-consanguineous marriage and widowed. No history of psychoactive substance use. Menstrual history, she attained menopause 10 years back. She takes mixed diet, regular bowel and bladder habits. She sleeps 4 to 5 hours a day. Appetite is normal, no history of any allergies. She has well-adjusted premorbid personality. General physical examination, she's moderately built and nourished. Excoriations are present over her body, and a single well-defined hypopigmented ulcer of size 7 into 7 centimeters was present on right buttock. No paler icterus, clubbing cyanosis, generalized lymphadenopathy, and bilateral pedal edema. Her vitals are stable. Systemic examination revealed no abnormality. Mental status examination, general appearance and behavior. Patient is well-groomed, eye contact is initiated and maintained. She's cooperative for the interview, rapport established, increased psychomotor activity, gait and posture are normal. Speech is relevant and coherent, normal reaction time and productivity. She expressed concerns about worms during the interview. Thought, delusion of parasitic infestation is present. Perception, no perceptual abnormalities. Mood, subjectively anxious. Affect is inappropriate, normal range, reactive, non-labile, and inappropriate. Her attention could be drawn and sustained. Her immediate recent and remote memory is intact, and she is oriented to time, place, and person. Average intelligence, impaired personal judgment, social and test judgment are intact. Insight is grade 3. My provisional diagnosis is F22.9, persistent delusional disorder unspecified according to ICD-10 diagnostic criteria. Differential diagnosis are schizophrenia, and excoriation disorder or skin picking disorder. Points in favor of my diagnosis are fixed false belief of infestation, excoriations over the skin, absence of stings, bites, or punctures over the skin, absence of medical evidence of infestation. All the routine blood investigations, MRI and biopsy showed no abnormality. Treatment, she was started on antipsychotic tablet risperidone 2 mg and tablet trihexyphenidyl 1 mg. Discussion. Persistent delusional disorders include a variety of disorders in which long-standing delusions constitute the only and most conspicuous clinical characteristic and which cannot be classified as organic, schizophrenic, or affective. Based on their content, delusions are persecutory, jealous, somatic, grandiose, and erotomanic. This case comes under somatic type of delusion, which is delusional parasitosis. It is also known as delusional infestation, psychogenic parasitosis, formication, or Ekbom syndrome. Patient experiences a fixed false belief that they have an infection with parasite, worms, mites, bacteria, fungus, or other living organisms. Patients are resistant and difficult to reason with to alter their thinking about their belief in the delusion. These are of two types, primary and secondary. Primary form of illness is a psychiatric disorder where the delusions of parasitic infection are the only symptom present. The secondary can be functional or organic. There are several mental disorders that can be accompanied by Ekbom symptoms such as schizophrenia, depression, dementia, anxiety, and phobia. Organic type is linked with hypothyroidism, anemia, B12 deficiency, hepatitis, diabetes, infections like HIV, syphilis, and cocaine abuse. Epidemiology, delusion of parasitosis is relatively uncommon. The incidence ranges from 1.9 to 27.3 cases per year per 1 lakh population. Average age is 57 to 61.4 years of age. There will be greater incidence in females than males. The pathophysiology may be increase of extracellular dopamine within the striatum of brain. Patients may present with excoriations or irritant dermatitis. Absence of physical findings and lack of any puncture, sting, and specific rashes would indicate an alternate diagnosis. Prognosis, it is better with medication compliance. Almost 50% have good response to medication. More than 20% report a decrease in symptoms. Less than 20% patients report minimal or no change to symptoms. Good prognosis is also related to higher social and occupational functioning, early age of onset, that is before age of 30 years, female gender, and sudden onset of symptoms and short duration. Delusional parasitosis generally doesn't inhibit the patient's ability to function, but rather serves as hindrance and persistent symptom. They generally have good response rates to atypical antipsychotic treatments. Patients can typically be tapered off medication over weeks and can respond well if symptoms reappear with reintroduction of treatment. These are my references. Thank you.
Can it be a hello? Yeah. Can you differentiate this between a tactile hallucination? How can you tell this as a delusion, not a tactile hallucination?
This is disorder of thought, sir. Delusion is basically disorder of thought, sir.
Can you,
Hallucination is
Yeah, I know.
perception.
Can you define delusion completely?
False, fixed, unshakable belief.
False?
False and fixed, unshakable belief, sir.
That's it. Is there a definition from a postgraduate? See, I believe that there is a god called Hanuman. I am delusioned. I meant to say your definition is not complete.
Even with proof, like.
And she is believing that insects are there.
Yes, sir.
How can it be delusion? You believe something. To call it as a delusion, there should be a evidence contrary to it.
Yes.
Right? You didn't tell that. So I'm coming back to my first question. How you're differentiating this from a tactile hallucination based upon your examination or history or whatever?
Sir,
Just a minute, don't mind, madam. I just want to know, how you proceed. Like we all heard that there is a tactile hallucination, and even she has taken a history of cocaine abuse. cocaine bugs where there is a common tactile hallucination? Just as a postgraduate, how you assess? Madam will answer.
Sir, tactile hallucinations can also be present in delusional parasitosis, sir. But they cannot be completely called hallucinations because the theme of hallucination is totally dependent on delusion, sir. Whatever the content of delusion she is feeling, that itself she'll perceive as worms.
Not convinced, madam.
Sir, actually, in this case, this patient is not saying that she can feel worms over her skin. She is totally fixed that she has infestation, but she is not feeling the presence of worms over her body. Only the thought is there, but there is no perception. First in thinking, sir, first in belief.
Yes, to prevent extrapyramidal symptoms due to respiratory.
Yes.
Extrapyramidal symptoms. See, first of all, you're adding an atypical antipsychotic.
Yes,
The extrapyramidal symptoms with atypical are rare
rare.
Sir,
until, madam, are rare. And again, extrapyramidal side effects, if you look, there are so many of side effects which are long term. Only this acute muscular dystonia is what you get initially. I think you can wait rather than adding a central anticholinergic at that age. Or is there any hypothesis, or what I know, when if you have studied the what dopamine release in the basal ganglia, you might answer this question adding triaxiphanidil.
Sir, this is an elderly female. She is about 57 years old. And while adding an antipsychotic, if she was admitted here, I would have never added trihexyphenidyl because I can observe her and I can assess if she develops EPS. So when we send a case in OP, even if it is a 2 mg risperidone, we used to add trihexyphenidyl because the side effects when it comes that can be very severe enough. So the patient might stop taking the medication also. So to avoid all those things, prophylactically we will start THP.
How many members are there in the family?
She lives with her son, sir.
Only one son.
Yes, sir.
Both of them, they live in one
Yes, sir.
house. That's all.
Yes, sir.
Means how do you differentiate it from an functional disorder? Means there are some people who might malinger or do something for primary gain, secondary gain. All these disorders are there. Wantedly, they will do. No, madam.
Sir.
Uh,
But in
I didn't find any, and means there is no criteria for telling that it is schizophrenic.
this is not schizophrenia, sir.
She told that it is schizophrenic.
No,
No,
sir.
sir,
No, she
differential
didn't
diagnosis.
tell. This is persistent delusional disorders, which is completely different from. Okay, it comes under schizophrenia spectrum, but this is not schizophrenia. Because in schizophrenia, there will be both that can
My
be.
question is, she might be having some problem with her son, so she might act or do something to for that secondary gain or something. Those functional disorders are there. How do you exclude that? That is my question.
Yes, sir. In case of a functional disorder, we definitely need to observe the patient for some time to differentiate it from malingering or functional disorder or a psychiatric disorder. But in this case, the disorder is severe enough that she got an ulcer over her buttock because of that continuous scratching. And even on her skin, there are total excoriations because of that scratching.
So you disposed of the case in OPD, no, madam?
Yes, sir. Because they were not willing to have an admission, so we disposed it in OP. Sir, this case was first, they first went to a general surgeon, sir. They examined the ulcer and they were doubtful that it could be a squamous cell carcinoma. So they sent it to dermatology department. Their biopsy was done, and after complete evaluation, they sent that case to psychiatry in view of delusional parasitosis. In this case, it's 6 months, sir.
Madam, one more doubt. Adding this anticholinergic, will it not affect the efficacy of your typical antipsychotics? Because if you look at the basal ganglia, the release, they are in balance. If dopamine goes down, there is counter hyperactivity of acetylcholine. Clinically,
these,
does it make sense? I mean, I don't know. Might
No,
be.
sir, it's The
a small study
action of
can be done.
antipsychotic is not decreased with adding trihexyphenidyl.
Thank you.
No, sir.
Might be there, unless you had a repeated counseling and other things.
Yes, sir.
She may not come out. Okay?
Yes, sir.
Is it clear?
Yes, sir.
Thank you. Now there is a faculty presentation by Dr. Deepthi Rani Ma'am, Associate Professor from the Department of Pharmacology.
Good afternoon, everyone. Respected sirs, my colleagues, and PGs. No. Yes, so today I am here to discuss the topic on recent advances in the pharmacological treatment of heart failure. So you already know what is heart failure, right? So who is going to answer what is heart failure? Yes. Please be interactive so that we can complete soon. My topic is regarding recent advances, so the intro part and existing treatment, everything you have to cover. Okay, so yes, what is heart failure? Come up. Failing of heart. So what happens if the heart fails? Medicine pages. ఎవరు లేరా? ఫస్ట్ చూడొద్దు ప్లీజ్. మీరే చెప్పాలి ఇక్కడికి వచ్చి నాకు. ఎస్ టెల్ వన్ బై వన్ ఒక్కొక్కటి చెప్పేసి కూర్చుండిపోండి. ఫస్ట్ వాట్ ఈస్ హార్ట్ ఫెయిల్యూర్? Is there any definition given by some associations? ఏ ఇయర్ మీరు? ఫస్ట్ ఇయర్. Okay, so you are telling that heart failure is unable to pump blood. Okay, so what could be the causes? Next one.
It might be structural or functional impairment of heart
Yes.
leading to left ventricular failure,
Okay.
leading to decreased ejection fraction
Yes.
less than 50%.
Okay. Is it reduced less than 50%?
They are grading based on ejection
Okay,
fraction.
okay. We shall see. Okay, then next one. I asked for the causes. What are
Might be
the
hypertension,
hypertension? Okay, you give it to him. He is very enthusiastic. What is the major cause of heart failure?
Myocardial infarction.
Okay. So you are telling that tissue death. Okay. Then anything else? Okay. How the body compensates this? Next one. Is there any compensatory mechanism? In case your heart fails to pump blood to the other parts of the body, how the body is going to compensate it?
It will activate the RAS system.
Yes, by? Okay, RAS. Then?
And increase the conductivity by tissue modification will be, that will be same.
Yes.
Yes, sir.
Neurohumoral. Okay. Okay. So how you are going to give the treatment based on this? Is this compensatory mechanism enough?
No, ma'am, we
What will it lead to? Does it worsen or improve the symptoms?
it worsen the symptoms because it we need to block the tissue modifying tissue modification, tissue remodeling.
Tissue remodeling. Blocks the tissue remodeling?
We need to block that.
We need to, okay.
We are
How?
giving AC inhibitors and ARBs.
Okay. So next one. Can you tell me some drugs which are given in CHF?
Aldactone.
Yes?
Aldactone.
What is it?
Aldactone, ma'am.
I'm sorry.
Spironolactone, ma'am.
Please tell me those. I don't know the brands.
Okay.
Spironolactone, then
Beta blockers.
beta blockers.
And
How many cases are you seeing? Congestive heart failure or heart failure cases. How many are coming to our hospital? Do you know?
many are
Hmm?
many cases, ma'am.
Many cases. So you already know what is the treatment going on, right? So only beta blockers and spironolactone are giving.
Hmm?
Which year are you?
First year, ma'am.
First year. That doesn't mean you don't know, okay? You should see the cases, right? Next one. You are the medicine PG?
Yes, madam.
Okay. So finally, name some drugs.
Diuretics, SGLT2 inhibitors,
Yes.
ACE, ARBs,
There is something called 4 pillars. 4 pillars for heart failure.
Yes.
What are those 4 pillars?
SGLT2 inhibitors, diuretics, ARNI, beta blockers.
What is ARNI? You should never tell the abbreviations, okay? Tell the full form.
Angiotensin receptor,
Mm.
neprilysin inhibitor.
Yes, okay, very good. Sit down. Thank you, everyone. So, PGs, I'm not going, I'm going to start now. So, today we are going to see the same thing what they have told already, the introduction and the burden, existing pharmacotherapy, pillars of heart failure, reduction, ejection fraction therapy, drugs in the clinical trials, and the newer targets and conclusion. So that definition, okay, as I said, it is given by American College of Cardiology Foundation or American Heart Association and Heart Failure Society of America. Guidelines, they define heart failure is a, as you said, it is not a disease, syndrome actually that results from any structural or functional impairment of ventricle filling or ejection of blood leading to cardinal manifestations like, what are they? What are the symptoms of heart failure? Dyspnea, fluid retention. So the European Society of Cardiology also have given some definition, that is a structural or functional cardiac abnormality resulting in reduced cardiac output or elevated intracardiac pressure at rest or during stress. Okay. So again, so now we can tell them as you have not defined those. Okay. 2 things are there. One is acute and the other one is chronic. So acute heart failure is nothing but acute decompensated heart failure. It refers to the rapid onset or worsening of symptoms of the heart failure. While the chronic one is, it describes the patients with long-standing symptoms or signs of heart failure, typically treated with medical therapy or the device therapy. And the incidence and prevalence. So as you said, many cases are coming to GEMS, okay? So like that, globally, more than 64 million people are affected by the heart failure. And the lifetime risk of heart failure at age 60 years is 33% for men and 28% for the women. It estimates, suggests a heart failure, that is the annual incidence is about 0.5 to 1 million in India itself. Then, as I said, as you have said, the compensatory mechanism, how it is occurring, because of the reduced cardiac output, there is baroreceptor dysfunction, and this leads to vasomotor center activation, which leads to increased sympathetic nervous system activity and increased vasopressin secretion. All these leading to increase in RAS and other symptoms, as you have said already. So the same thing, and you can see the different drugs in the different sequence of events during this compensatory phase. We shall see them. So these are the symptoms: shortness of breath, difficulty focusing, fatigue, confusion, lowered ability to exercise, heart palpitations, dry hacking cough, and generalized edema. So what is the classification of heart failure based on the physical activity? Okay, so the first one is class 1. So 4 classes are there. So from ordinary physical activity to symptoms of heart failure, or and that means they couldn't do anything. They should be even at rest. They are the symptoms are existing. So first one is ordinary physical activity does not cause undue fatigue, dyspnea, palpitations, or angina. Class 2 is comfortable at rest, but ordinary physical activity might get some symptoms. And next class 3 is they are comfortable at rest, but they could do only the even less than the ordinary physical work they couldn't do. And in class 4, the symptoms are very severe that even at the rest, the symptoms are, they are very seen even in the rest. Next one is stages of heart failure. So we have seen NIHA things, that is New York Heart Association functional classification. And here you will see the stages of heart failure given by American Heart Association. Okay, so stage A is at risk for heart failure. So the symptoms structurally or functionally they are not seen, but they are at risk. Stage B is pre-heart failure. Structural abnormality is seen, but functionally they are not much seen. And stage C, here you can see symptomatic heart failure. Symptoms and signs are seen here. And stage D, that is advanced heart failure, where marked heart failure symptoms are seen that interfere with the daily activities. So as you said, HFR-EF, that is heart failure with reduced ejection fraction, is less than or equal to 40%. Someone told it is 50%, right? So it is less than or equal to 40%. And heart failure that is improved with improved ejection fraction is previous LVEF that is less than or equal to 40%, and a follow-up measurement of seeing more than or equal to 40%. And then you have mildly reduced ejection fraction, that is from 41% to 49%. And then you have preserved ejection fraction, that is LVEF more than or equal to 50%. What is the normal ejection fraction? See, these are all reduced, improving, mildly reduced, and preserved. What is the normal? Preserved means almost equal to normal, right? So, from 55 to 75. Okay. Next, these are commonly used drugs. Sorry, the slide is not clear. Still, you have told all the drugs, chronic systolic heart failure and acute heart failure. You can see the drugs used are diuretics, aldosterone receptor antagonists, ACE inhibitors, angiotensin receptor blockers, and SGLT2 inhibitors, beta blockers, cardiac glycosides like digoxin, vasodilators like, can you name some vasodilators? Vasodilators. మిగతా పీజీస్ కూడా ఎంబీబీఎస్ చేసే కదా వచ్చారు. ఎనీవన్ కెన్ ఆన్సర్. ఎస్, hydrazine, nitroglycerin nitrates, yes, and some vaptons also. They are also acting as vasodilators. And then next you have resynchronization and cardioverter therapy. Then in acute heart failure, you have diuretics, vasodilators, beta agonists, bipyridines, natriuretic peptides, and left ventricular assist device. That is non-pharmacological treatment. Then, so depending upon the symptoms and the stages, again, the management is divided into for stage A and class, that is a pre-failure thing, that is pre-heart failure. You can see no symptoms, but at risk. So the risk factors, they should be treated, like treat obesity, hypertension, diabetes, hyperlipidemia, etc. Okay. And next one is symptoms with severe exercise are seen. For those people, you can go with the basic things: diuretics, ARBs or ACE inhibitors, beta blockers, and you can go with MRA also. Okay. What is MRA? Mineralocorticoid receptor antagonist. Then you have symptoms with marked exercise. Okay, marked or mild exercise. So you have to add. So basic ones are already they have laid. What are the basic things? Beta blockers, diuretics, AC inhibitors, and upon that you have to go on add on the drugs like SGLT2 inhibitors, aldosterone antagonists, digoxin. What is CRT? CRT, cardiac resynchronization therapy. It is there already. Okay. Next one is ARNI, as you said, and hydralazine or nitrates. Then if severe symptoms at rest are there, maximal medical therapy, whatever therapy you can give, you will give, and still it is there, you should go with transplant or LVAD. What is LVAD? Left ventricular assist device. We have seen already. Next, the same things again and again. So systolic heart failure and diastolic, what is the difference? How you will manage? What are the different drugs that are given differently in different types of heart failure? So mainly you can see why they are given. Okay. So why they are given for the cardiac output? First you see systolic heart failure, cardiac output is decreased, and in case of diastolic heart failure also cardiac output is decreased. What about ejection fraction? You see what is happening with ejection fraction? In case of systolic heart failure, ejection fraction is reduced, but in diastolic heart failure it is normal. Why? It is said to be preserved. Kada? Enduku? Systolic heart failure ante enti? They are unable to pump, contract. సో అందులోపల నుంచి అసలు బయటకు రావట్లేదు. ఓకే. సో కార్డియా ఎజెక్షన్ ఫ్రాక్షన్ తక్కువ ఉంది అని చెప్పొచ్చు. వాట్ అబౌట్ డయాస్టోలిక్ హార్ట్ ఫెయిల్యూర్? వాట్ ఈస్ డయాస్టోలిక్ హార్ట్ ఫెయిల్యూర్? డయాస్టోలీ చెప్పండి ప్లీజ్. డయాస్టోలీ, వాట్ ఈస్ డయాస్టోలీ? సిస్టోలీ అంటే కాంట్రాక్షన్ అన్నారు. డయాస్టోలీ అంటే ఏంటి మరి? మళ్ళీ కాంట్రాక్షనా? Filling, relaxation. Okay. Why are you not reading? Okay, so relaxation of the ventricles for the filling. So ikkada relaxation sarigga avatledu. So it cannot take the blood at all. So how much blood it can pump out? So the ejection fraction will remain the same. Okay, contraction jarigipotundi kani it cannot fill the blood inside. Then so the drugs given in systolic heart failure are diuretics to reduce the symptoms, first line therapy if edema is present, and in case of diastolic heart failure it should be used with caution. Okay, so if you go on like this, most of the drugs can be used in systolic heart failure, but in diastolic heart failure you should give the drugs very cautiously. Okay, so what are the traditional pillars of heart failure reduced ejection fraction therapy? You said already. So beta blockers, so they reduce morbidity and mortality by inhibiting sympathetic activation. Bisoprolol, metoprolol, carvedilol, and the trial is CBIS-2 trial. It showed 5% absolute risk reduction in mortality. AC inhibitors, which block the conversion of angiotensin 1 to angiotensin 2. Why we should block this conversion? In the conversion apeyali angiotensin 2, we don't need angiotensin 2. Why? It causes vasoconstriction and cardiac remodeling. Okay, so AC inhibitors, yes, they are enalapril and captopril. So the trials were consensus and SAVE trials. They shown that there is reduction in mortality. Then you have ARBs, angiotensin receptor blockers. The example is candesartan. Okay, they too work as AC inhibitors, but there is slight difference. What is it? With regard to side effects, AC inhibitors ki ARBs ki enti difference? Yes. So AC inhibitors, they also block or inhibit or degrade bradykinin. So the levels of bradykinin are increased with ACE inhibitors. What happens if bradykinin levels are increased? It is an inflammatory mediator. So angioedema, cough, those kind of adverse effects are seen. Okay, dry cough especially. So here with ARBs, it is not seen. Mineralocorticoid receptor antagonists, which prevent sodium and water retention. Example, spironolactone. What is the other MRA other than spironolactone? Eplerenone. Okay, and the trial was RAILS. It showed significant mortality reduction. Same thing, so different ACI drugs and angiotensin receptor blockers. So they are not only used in heart failure but also in diabetic nephropathy and hypertension. As we have said, it causes hypotension, hyperkalemia, but no cough or angioedema. Then you have beta blockers. They suppress arrhythmias, inhibition of renin release, prevention of MI, and adrenergic overstimulation. And next is mineralocorticoid receptor antagonists, spironolactone and eplerenone, which blocks cytoplasmic aldosterone receptor in the collecting tubule. So they don't not only decrease the salt and water excretion, but also they decrease the remodeling. Okay, sorry, increase the salt and water excretion, but also they decrease the remodeling. Aldosterone causes myocardial vascular fibrosis and baroreceptor dysfunction. For that, we are going to block the receptors. Then you have uses like in case of heart failure, stage C, NIHA class 2 to 4, we can use these diuretics. Okay, I mean MRS. Then what is the side effect? These are also called as potassium sparing diuretics. So there will be hyperkalemia. We should monitor for the potassium levels. And it has sterogenic property, I mean anti-androgen action. It might lead to impotence and gynecomastia and painful breast swelling and dysmenorrhea. Now we are going to see what are the novel pillars for heart failure reduced ejection fraction therapy. So what are they? First one is ARNI. ARNI you said already. AR means angiotensin receptor and N means neprilysin inhibitors. So what are the drugs here? Sacubitril and valsartan. Okay, sacubitril and valsartan. Why neprilysin is important? Why neprilysin as a target it is seen or it is taken as target? What is the role of neprilysin? Yes, please don't talk. It degrades ANP and BNP and CNP, all the natriuretic peptides. What is the role of natriuretic peptides? They have roles like vasodilation, decrease cardiac hypertrophy or fibrosis, and increase natriuresis. Okay, and when you block the neprilysin, it can also decrease the levels of angiotensin 2. Sorry, yes. Then you have sodium glucose cotransporter 2 inhibitors. What are they? What are the drugs under SGLT2 inhibitors which are commonly used? Dapagliflozin and what is the other one? Empagliflozin. Actually, it is a serendipity. What is serendipity? What is serendipity? Accidental discovery. Why? SGLT2 inhibitors are used for what? For what purpose they have discovered? Yes? Diabetes, right? So they have seen that it also has cardioprotective properties. For that cause, now they are doing trials, many trials, and they have seen that they are giving promising results, especially in heart failure reduced ejection fraction. So in DAPA-HF trial, 18% reduction in CV mortality is seen. And next one is, so ARNI in detail, what is happening? It is used in chronic heart failure. It reduces mortality and hospitalization. But toxicity can be seen like hypotension and angioedema. Then one more drug was there, that is omapatrilad. Do you know what is somapatrilat? It is neprilysin inhibitor plus ACE inhibitor. Actually, what was the sacubitril and valsartan? It is a combination of neprilysin inhibitor and ARB. Okay, so with this somapatrilat, they have seen more of angioedema and more of dry cough. That is very serious. That's why they have stopped this drug. Okay. Then SGLT2 inhibitors, dapagliflozin, empagliflozin. So it was first approved for this heart failure in 2020. Likely inhibition of glucose uptake, improved diuresis, decreasing preload, and NAH exchanger inhibition. So what are the different cardiac properties or cardiac effects, vascular effects that are seen with SGLT2 inhibitors? So overall, it is having very much good prognosis on heart failure. So these are now became one of the major pillars for what you call therapy of HFrEF. Okay. So these are the different trials they have done for the efficiency of SGLT2 inhibitors. So DAPAM is for dapagliflozin. It showed the particular goal of any treatment of heart failure is to reduce the mortality and also reduce the hospitalization. Okay. For that, they have seen in every trial they have seen the promising results. So still they want to see for. And this is the only group of drugs, SGLT2 inhibitors. They have also shown effect on the HFpEF. What is HFpEF? Preserved ejection fraction. So most of the other groups of drugs, they are all very much good at like improving the prognosis or decreasing the mortality in case of HFrEF. But no drugs are very much promising like SGLT2 inhibitors in case of HFpEF. Okay. Then iron carboxymaltose in heart failure. So what is this iron carboxymaltose? Everyone should tell. What is this? IV iron preparation, right? So why you should give this? So they have seen that because of anemia and other things, there is reduced or impaired exercise tolerance. So when you give this iron, they have seen little improvement in the cardiac properties also. So the most common, so they are still under trials, and sometimes some cardiologists, they are telling that this might become the fifth pillar also. Okay. So the most common adverse effect of iron carboxymaltose is hypophosphatemia. Why? Because it is due to increase in urinary phosphate excretion from the upregulation of phosphaturic hormone FGF23. So FGF23 is causing this phosphate to get excreted in the urine. Because of that, there is hypophosphatemia. And this is all happening because of the iron carboxymaltose. So these are the different trials where they have seen improvement in the quality of life also. So improve symptoms and quality of life. FAIR HF, Confirm HF, Affirm AHF, and Ironman. Okay. Ironman 2022 trial and Heart FID, it is under trial. The trial is still going on. Then Finerenone. What could be this Finerenone? Like your eplerenone. Okay. So it is one of the mineralocorticoid receptor antagonist, but it is selective non-steroidal. Okay. It has been shown to reduce cardiovascular events in patients with chronic kidney disease and type 2 diabetes mellitus. But the most common adverse effect is, obviously, it is hyperkalemia. So these are the different trials with this fine arts finality. So the trials are still going on with this Finerenone. Next one is semaglutide. So it might be the new era of cardiometabolic drugs in heart failure patient. So it is one of the GLP-1 agonist. Again, it is also which drug? Anti-diabetic. Okay. So it is showing efficacy in both weight loss and also reduction of major adverse CV events, nothing but MACE. Okay. So the trial is SELECT trial. In those diagnosed with HFrEF, demonstrated a significant reduction in the composite HF endpoint, that is CV death, hospitalization, or urgent hospital visit for heart failure. So as I said, this is the primary endpoint for any drug. Next one is patiromer and sodium zirconium cyclosilicate. So what are these drugs? Any idea? These are potassium binders. So when you give drugs like AC inhibitors or potassium sparing diuretics, what is the major adverse effect or side effect? You can see increased potassium levels. So that can be like those drugs can be given with this patiromer or sodium zirconium cyclosilicate, so that effect of hyperkalemia can be reduced. But as there was one trial going on that was prioritized HF, but it got prematurely halted due to our COVID-19. No more update on this. Okay. Next one is other different molecules, other target molecules of this heart failure. You can see was istaroxime. What is the name? Istaroxime. Okay. So what it is doing? Inhibition of sodium potassium ATPase and increased SERCA2 ATPase activity. What is the other drug which causes this inhibition of sodium potassium ATPase? Furosemide. Sodium potassium ATPase. Digoxin. Okay, digoxin. Next one is omecamtiv mecarbil. So that istaroxime is under phase 2 trial. Then you have omecamtiv mecarbil. It is the mechanism is cardiac myosin ATPase activation. That is, it is forcefully or dragging the myosin for the contractility, but without any much oxygen demand. Okay, consumption. But it is not approved by FDA because they are telling that whatever results you are showing, it is insufficient. We need more trials. Then you have pro-ANP, that is ularitide. It is also not approved by FDA, still under trials. Then ANP, agonist or the target is ANP. The drug is carpiritide. Then recombinant form of relaxin 2. What does relaxin can do? What is the role of relaxin? Can anyone tell? Smooth muscle. Okay, smooth muscle relaxation. So vasodilation. Okay, so relaxation. Then you have selective cardiac myosin inhibitor, mavacamten. Then soluble guanylate cyclase activators. What are those drugs? These are very important drugs for you. You might get a question. Sinaciguat, riociguat, and vericiguat. And these are, I think, vericiguat is now under use, okay, for HFrEF. Then ureglin GGF2 protein synthesis or an analog semaglutide. Okay, semaglutide, and it is under preclinical trials. Then you have levosimendan, which sensitizes the troponin system to calcium. It also inhibits PD. PD means phosphodiesterase, and it also has inotropic action. So when you see this vericiguat, it is important for you. As I said, you might get a question on it. And it is 2021 FDA approved. What is the mechanism of action? It enhances the sensitivity of SGC. What is SGC? Soluble guanylate cyclase to NO. Okay, and this might lead to increase in cyclic GMP levels, which leads to reduced cardiac remodeling. Okay, hypertrophy, fibrosis, stiffness, and ventricular remodeling. What is the most advantage of this is it is having 30-hour half-life that supports once daily administration, high bioavailability, and very tolerable. There are no drug-drug interactions. And these are the different trials for this vericiguat mecarbil. Okay. So the trials are Socrates reduced, preserved. Reduced means for HFrEF, and Socrates preserved means for HFpEF, and did not decrease NT-proBNP or LAV. So it is showing effects on HFrEF but not at HFpEF. No improvement in physical limitation score of KCCQ. What is KCCQ score? You should know about it when you read about CHF. Okay, Kansas City cardiomyopathy questionnaire. There is a questionnaire. When you do any thesis on CHF, you should know about this KCCQ scoring. Okay. Then about omecamtiv mecarbil, as I said, they have done very good trials, but FDA doesn't approve. But the trial was Galactic HF trial, and it has shown lower incidence of heart failure events in patients with severe systolic dysfunction. Omecamtiv mecarbil is safe and well tolerated medication like your vericiguat. So what is the mechanism of action? This is also important question for you. నా పీజీ టైం నుంచి అడుగుతున్నారు దీన్ని. వాట్ ఈస్ ద మెకానిజం ఆఫ్ యాక్షన్? ఇంక్రీజ్ మయోసిన్ హెడ్ బైండింగ్ టు యాక్టిన్ డ్యూరింగ్ సిస్టోలీ, increase force generation during contraction. So these are the trials, Cosmic HF and Galactic heart failure. So overall, these are the different trials that many drugs have undergone, like Paradigm heart failure for ARNI, DAPA heart failure HF trial for SGLT2 inhibitor, that is dapagliflozin, Victoria trial for soluble guanide cyclase stimulator, vericiguat, and Galactic heart failure for cardiac myosin activator, that is omecamtiv mecarbil. So you can see the different times, okay, timelines. Then Emperor reduced, empagliflozin, and Soloist WHF. What is Soloist? For sotagliflozin. So we said only about two things, dapagliflozin and empagliflozin. The other one was sotagliflozin. So overall summary of what we have discussed till now. So this is the thing, SGLT2 inhibitors, vericiguat, omecamtiv mecarbil. One of the other drugs was acetazolamide also. It has shown promising results in acute decompensated heart failure also. Then IV iron, that is ferric carboxymaltose, and GLP-1 agonist, semaglutide. Still, you have many other targets like interleukin-1 inhibitors, antifibrotics, and stem cell therapy also. Okay. But there is some articles they have given that this might, the LVEF, now we are seeing for HFrEF, but we might, a novel approach will be there, that is HF and EF. What is an? Any reduction. Okay, any reduction of ejection fraction. And in future, the drugs might go. Okay, this might come up. Okay, biomarkers, heart failure, phenotypization, CMR. What is CMR? Is it given there? Cardiac MRI. Then GLP-1 receptor and agonist. Then genetic testing, exercise evaluation, prognostication, and targeting inflammation. So these are the things in future they will be showing. Okay, not about the other investigations what we are doing now, or what is the drug therapy we are giving now. Okay, so these are the takeaway points. What are they? ARNI, beta blockers, MRAs, and SGLT2 inhibitors are the primary treatment for HF, REF. ఇప్పటికైనా ఇస్తారా ట్రీట్మెంట్? నెక్స్ట్ ఎమర్జింగ్ థెరపీస్ వెర్సిగువాట్, omecamtiv mecarbil కాకుండా మిగతా కూడా ఉన్నాయి. ఓకేనా? అండ్ ఫ్యూచర్ డైరెక్షన్ ఈస్ పర్సనలైజ్డ్ థెరపీ బేస్డ్ ఆన్ పేషెంట్ ఫీనోటైప్ will shape future treatment paradigms. So these are my references. Everyone can get up now. Thank you. అంటే గోస్లో అని అంటారు సార్, నాకు తెలియదు సార్. ద టైమ్ గివెన్ ఫర్ మీ ఇస్ వెరీ షార్ట్ సార్. ఈ టైం కాదు, నేను చదువుకునే టైం. సో నేను మళ్ళీ చూసి మీకు చెప్తాను. No sir, still they are only compared with placebo only sir, and given as add-on. డిజిటాలిస్తో కంపేర్ చేశారా? కంపేర్ చేయలేదు సార్. ప్లస్ అంటే
So can the old adage of contempt for old and craze for all new things still holds good? Why? Is it proved useless? Po- Be-
No, sir. Digoxin is the only inotropic drugs. మనకి డోబుటమిన్ అదర్ సింపథమ్ మిమెటిక్స్ ఉన్నాయి. When we need to improve the force of contractility, like ejection fraction, and imagine the simultaneously patient is prone to a coronary heart disease. Apudu, digoxin is the only drug which increases force of contraction without increasing heart rate. It has an additional parasympathomimetic activity. Instead, it decreases the heart rate. Whereas other inotropes, they increase force of contraction as well as they increase heart rate. So ultimately, load on the heart increases with other inotropes. So in this scenario, definitely digital is hold till today. It's the best drug. If the patient is more prone to coronary artery disease, and you need to improve the ejection fraction without increasing heart rate. Cardiologist can answer better, sir. Yes, sir. All this recent nebivolol and they are doing better than all bisoprolol, metoprolol, nebivolol, and even carvedilol, because nebivolol has an additional antioxidant property, they say, sir, but none of the trials have shown a significant result. They are using nebivolol as well. Antioxidant, cardioprotective.
Nebuvolol కూడా NO action ఉంటుంది.
Ultimately, better beta blocker ఏంటంటే long run without compromising the conduction or heart rate brady అవ్వకుండా వాడితే there is a theory called catecholamine induced toxicity which is there in the heart rate, and the way when we use beta blockers it inhibits the renin release also. మనకు simultaneously RAS activity కూడా తగ్గిపోతుంది when we use beta blockers. So that's why even that there was a total shift of beta blockers, previously it was not at all used ani వచ్చింది సార్. దాని తర్వాత now it is not used in acute heart failure where EF is less, where the heart is dependent on sympathetic nervous system. But when it comes to chronic, it is one of the gold standard drug for treatment of heart failure, especially because heart will undergo something called remodeling, difficult to treat. That can be prevented better by beta blockers as well as AC as well as spironolactone, because even we find aldosterone receptors in the myocardium. It is not just a volume overload or something done by the aldosterone. It stimulates the heart to undergo kind of hypertrophy and other things. You can read those things in Harrison. These all three could give a better heart structure function on the long run.
Thank you, sir. Thank you for your patient listening. పడుకున్నారు చాలా మంది, బట్ స్టిల్ థ్యాంక్ యూ.
Especially the respected PGs, if you just plan a little, నీకు ఒక మంచి లాంగ్ క్వశ్చన్ అయిపోద్ది. Like you can prepare
No,
for
all PGs, I
final
think
exam.
it is,
Especially, say if that particular dermatology PG is read, I mean, some other branches will be least interested. At least if you know that topic is related to medicine or obs gynae, psychiatry, కొంచెం ప్రిపేర్ అయ్యి వస్తే will feel very interesting. కొంచెం యూజీ నాలెడ్జ్ బ్రష్ అప్ అయిపోతుంది. When you read for yourself, it will be easy. సో అగైన్ డైరెక్ట్గా ఎక్కడో ట్రయల్స్ అంతా తీసుకొని చదవాలంటే చాలా టైం పోతుంది మీకు. యూ కెన్ సేవ్ దట్ టైం by
If you want
this,
references, I can give you.
CMEs. You can take those PPDs or reference. కొంచెం ఒక హాఫ్ అన్ అవర్ యూటిలైజ్ చేసుకుంటే మీ ఫైనల్ ఇయర్ ఎగ్జామ్ టైం బర్డన్ తగ్గుతుంది. రైట్, థ్యాంక్ యూ. ఇది అదే మేడం క్వశ్చన్స్
Question,
వస్తాయి.
madam.
జస్ట్ యూ థింక్ దో CME as a preparation for your final exam. Half an hour a week will save a lot of time of you during when you plan to write your final exam. Thank you.
You should thank them for coming and listening.
Just a tip, but I don't know how they use it. Thank you.
Okay.
Thank you, madam. So about today's session, all the three has performed equally. Everyone got the same marks. So So today all the three are winners.